As healthcare providers, we often find ourselves dealing with patients who, despite our best efforts, do not adequately follow our recommendations for self-management, be it taking medications appropriately, making dietary changes, becoming physically active, completing recommended lab tests, or avoiding risky behaviors. How can we more effectively help these patients? This program will present and demonstrate some simple strategies for engaging patients and promoting effective self-management. With the limited time constraints of modern clinical practice, incorporating all the techniques of this video may seem overwhelming. Depending on the reality of your practice, you will find some of these ideas will work better than others. The overall goal or spirit of this program focuses on the need to listen to our patients, a simple skill that can sometimes seem quite difficult.
Hi, my name is Bill Polanski. I'm a clinical psychologist, I'm a certified diabetes educator, I'm also an associate clinical professor at the University of California at San Diego, and president of a new nonprofit organization called the Behavioral Diabetes Institute. I've spent the past 20 years of my life focusing on the psychosocial aspects of living with chronic medical illnesses, both as a clinician and as a researcher. I'm here today to talk with you about one of the more difficult issues that healthcare providers face, especially when they're dealing with patients with chronic medical illnesses. And that's the problem of what is often known as quote-unquote non-compliance. When you're working with patients who seem unmotivated to want to make some of the healthy behavior changes that we wish for them so they can live longer and healthier lives. One of the things that we understand now is that there are in fact very, very few patients who really are unmotivated to want to live a long and healthy life. The issue, in fact, is quite different. It's not that they are unmotivated, it's that they face obstacles, sometimes very, very practical obstacles that lie in their path. Things like depression, things like not exactly understanding what they need to do to be effective, sometimes real-life obstacles having to do with the cost of medications or other things. In today's program, we want to face some of those obstacles and again see if we can be of help. In this first section, we're going to be focusing on engaging the patient. What we mean by that is making sure that very early on as we begin an interaction, that we make certain that we ask for and include the patient's own agenda in today's discussion. To do that, very simply, we want to make sure that we ask questions. We ask questions like, what do you want to make sure that we address today, Mrs. Smith? Could you tell me something that's been tough for you in terms of trying to manage your diabetes or your heart problems? There's a couple things I want to make sure we address here today, but before we do, I want to make sure we make room for addressing what you think is important. So when you think about your diabetes, I'm wondering what are the important things you want to make sure we talk about today or that we try to resolve? What would be useful for you?
Well, the thing that would probably be most useful to me.
By including the patient's agenda in the interaction between patient and provider, our patients will be interested in exactly what we'll be talking about today and engaged and excited about any suggestions we may have for making positive changes in the future. Pat, I'm glad to see you.
Thank you.
There's a bunch of things I want to make sure we cover today, but before we start, I'd like to ask you, what's your agenda? What do you want to make sure we address today? What are some of the issues that are important to you?
Taking my medicine. I don't take it regularly. I was having problems with
By starting with the patient's agenda, we are guaranteeing the patient that today's visit will be of personal interest to them. Therefore, they are more apt to feel engaged almost immediately. Of course, this does not mean that the provider's agenda for the current visit is not important, merely that it should not come first.
Paul, it's nice to see you again. And there's a bunch of things I want to make sure we cover today, but I know you may have some of your own issues of concern. So first of all, let me just ask you, how are you doing with your diabetes? How well are things going, or how poorly are things going?
Well, my diabetes is not going well at all. My sugars are very high. My average is about 288. I'm getting more and more depressed with it. I stay in bed because of it. I don't want to face the world. Sometimes I feel like there's no reason to go on. I do what I'm told to do, taking my insulin properly, trying the new types of drugs that doesn't seem to do any different. Try to eat like the doctors say, the dietitian tells me, and it doesn't seem to do anything, and my sugars just seem to stay high.
You're getting pretty discouraged, and it sounds like for good reason. If your best efforts aren't leading to the results you want, you're getting pretty depressed. And certainly we know the hallmark of getting depressed, or one of them, is when you feel like you're so tired you can't even having to get up and go to get out of bed in the morning.
Right.
By the way, another common symptom is when people feel like they're losing their ability to enjoy things. Have you noticed that as well?
I diagnosed 10 years ago with diabetes, and I've seen it just really just take over my life. Not, I can't be in charge of it. It ruins everything. I can't do anything normal, like, and I want to be normal, like a normal person. So instead of facing what I have to face on a daily basis, I stay in my room in bed, and I'm weak, and I have other health issues. So the diabetes is just taking over, and it's not, I think that it's not fair, and I get very angry, and I hate diabetes. I hate even the word.
If we did something useful today so that your time here would be worthwhile, what would we accomplish?
A reason to want to do better.
We must remember that we and our patients are on the same side, and working within very limited time constraints, we must find a way to encourage them to believe that managing their diabetes is worth their while. Often this does not seem so easy, but it is one of our most critical jobs. Otherwise, our many prescriptions and recommendations may come to naught.
My caretakers tell me that I should eat every 4 or so hours. Should eat so many snacks a day and so many meals a day. And with my schedule, it is very hard for me to do that.
Tell me more about that. How does your schedule conflict with this idea of eating multiple times a day?
Well, one reason is I'm usually up early in the morning time. And usually when I get up that early, I'm not hungry.
Okay, so one is you're just not hungry. The other is you get busy with other things, like work.
That's true.
Or other things?
Work or any other activities. And then I just totally forget about eating.
Sounds like you get pretty focused on what you're doing.
Yeah.
And eating is just not very important.
And then I realize that at the end of the day is almost ended before I'm hungry or before I really want something to eat.
An important part of engaging the patient is being curious enough to drill down with them to get more details. Since the focus of our efforts is on promoting behavior change, we must do more than just listen to the patient's story. Instead, we want to focus very actively on identifying some important areas where the patient may be interested and willing to make positive, healthy behavior changes. To be truly successful here, we would not do this by simply stating our own goals for the patient. Instead, we would help the patient identify from their own perspective the necessary changes that need to take place.
I know you're on a bunch of different medications, and I know the diabetes medications you take are glipizide and metformin. And I noticed that just talking about this, though, it looks like it's really upsetting for you.
Yeah, it is, because I don't like to take medicine. I hate to take medicine.
I got the sense that taking medications for you, the more pills you take, it's almost like it's a statement that you must be really sick.
I don't feel sick, but I know I am. I have type 2 diabetes, and I have thyroid problem, and they said I had 200 and something for cholesterol, so they gave me a pill for that, and high blood pressure, and they said they were giving me high blood pressure medicine because they were giving me diabetic medicine.
We as providers don't often ask our patients to explain why they are making the decisions they are making. From our perspective, patients often make choices that are not grounded in common sense, choices that may even seem potentially harmful to them.
So when you think about taking these medications, you said you've really stopped taking most of them over the past month, or really not taking as much as you need to. How come?
Well, I was stressed. I was stressed, and I didn't want to take them. And then when I was taking the medicine, about 2 o'clock or so, I started shaking, really shaking. So I had to go rush and find something to eat real quick. And then when I wasn't taking the medicine, I wasn't getting this feeling. I was feeling healthy. I was feeling okay. But I know I have to take the medicine.
So there's something about the medications you're taking, and in particular we know it's probably that glipizide you're taking that was actually causing you to have these low blood sugar feelings. And I guess that makes sense. If you're taking a medication, you're not really aware of it having any benefit, but you're aware that it actually feels like it's making you feel bad. I can see why you wouldn't necessarily want to be taking it.
Yeah, because
We must believe that because they come to us, they do want to live long, healthy lives. Indeed, most patients do understand that diabetes is a serious disease that can be harmful to their health.
I know I have to take the medicine for my own health. And I've been going to diabetes classes for 4 years. And
The critical issue is that there are often an array of problematic barriers, personal obstacles that stand in their way. To address these barriers, we must first make the effort to understand the problem of diabetes from the patient's perspective. We must make this effort before we offer our own advice.
A couple hours before I go to bed, which is around 2 o'clock, then I want to eat. And when I eat. I don't just eat a little bit. I guess I make up for what I didn't get that day. And so then I'm really full. And so the next morning, then I wake up, my sugar is really high.
Well, no wonder you're not hungry in the morning. You're still full from the night before.
The night before, you're
that
probably
makes
right.
perfect sense.
Yeah.
It's clear what you want to do, I understand. That if this is going to be a useful time for you, it'd be nice to do something about this issue you're facing about your healthcare providers wanting you to eat more regularly during the day.
An important thing to remember is both patient and provider are experts in chronic illness. The provider is an expert because they have information, training, and experience across large numbers of patients, while the patient has the personal expertise of living with their illness in the context of their life.
I've lost all these reasons, and I think my depression is what causes that.
What's so important about what you're saying is it would be easy for us to get focused immediately on talking about some nitty-gritty diabetes things about eating or exercise, and that would certainly be pointless because, as you're saying, you don't have much get up and go, you don't feel very motivated to do anything, you've made efforts before, they haven't really led anywhere, so we really have to talk about what happened to your oomph and what we can do about it.
Right.
When our patients understand that we are interested in their struggles with diabetes and in their perspective on the matter, they are much more likely to be interested in anything we have to say and to be open and interested in addressing their diabetes care. This is what is meant by engaging the patient.
The second strategy we want to focus on is exploring importance. This is critical because we know that sometimes we just assume that whatever it is we want to talk about with our patients, whether it's the idea of regular exercise, taking their medications, well, of course they must understand this is important. And we skip right on by into planning for change. And we can't understand why our patients often respond with, yes, but, yes, but, yes, but. And this is because we skip this important element. The goal is to begin to understand how patients see this idea of some somewhat specific behavior change as, at least to some degree, valuable, meaningful to them, but that on the other hand, there's some ambivalence. On the other hand, they also see this as not important and not as meaningful as we might hope. And once we understand that, or I should say, at least if that's true, we can begin to problem solve and take action around that issue of importance. Because if we don't do that, especially if importance is relatively low, we're simply unlikely to be successful when we get to trying to help people make and maintain positive changes.
One way to begin this process is through the use of the importance scale. Adapted from motivational interviewing, the importance scale encourages patients to reflect and consider how worthwhile behavior change would actually be to them. Through a series of structured questions, patients are able to identify the pros and cons of change, which, without any further intervention, can often serve to enhance the patient's enthusiasm about behavior change.
Let me think about this with you in a more formal way, what will help me. And it's this idea of importance and how important it is that you should be taking your medications more regularly. So, and the way I like to think about it is if we think about it on a scale that goes from 0 to 10, I'll write it out here for you because I think it's important to look at, And if we think of 0 being not important at all, when I think about taking my medications, has no effect, worthless, pointless, forget it. All the way up to 10, taking my medications, by far the single most important thing I should be doing in my life, more important than whether my children breathe or anything else in the universe. So I'm assuming that the importance of taking your medications lies somewhere between 0 and 10. So as you think about it, what number would you give to how important it would be for you to be taking your medications now?
I know it should be 10, but like I said, 4 probably.
Okay, so you're at a 4. And a 4, like many people, means that you have mixed feelings. There's reasons why you think it might be useful, reasons why it might not be so useful. So let's look at both of those. Let me write down 4 here, just so I can remember. So you're about a 4.
The common mistake is not to recognize that our patients have mixed feelings, and not to recognize that we all, in some way, experience ambivalence about making behavior changes.
As we begin to think about how this might occur, how come, first of all, it isn't less than 4? How come you didn't give me a number less than 4? Meaning that you're not thinking of exercise as incredibly unimportant.
I'm thinking, well, maybe I should care more about myself, than I do. Because right now I don't care.
Mm-hmm.
And like I said, like I told you earlier that why go on?
Mm-hmm.
I have heart disease, I have diabetes.
As demonstrated in the work of our motivational interviewing colleagues, it is through the respectful recognition of ambivalence and the working through of those mixed feelings that we can help our patients to be more ready to make positive behavior changes.
So that makes me think maybe 4 is too high.
Yeah, well, maybe a 2.
So maybe a 2.
Yeah.
Okay. So now that we know that in fact it's not that important, but everyone's sort of suggesting it, but still 2 is more than 0.
Yeah.
How come it isn't 0? What is it about this idea even of starting some sort of walking that makes you think it's not completely unimportant?
Maybe it would be good for me. Maybe it would help, and I am looking for answers.
And when you think about the possibility that it might help, how do you imagine it might help?
Maybe it would get me out of the house.
Well, I can guarantee you walking will get you out of the house.
But maybe my sugars would come down a little bit, because they say that exercise does help that. They also say that I think your endorphins work better, and that helps with depression. I think I've heard that somewhere. And I don't know, maybe I'd start feeling better about myself.
Okay, so the reason it's not 0 is you said 3 things. Number 1, it might help to bring your blood sugars down, might cause a little endorphin rush so that you might feel a little less depressed. It might actually get you starting to feel better. And just generally the fact that you'd be doing something also might start to make you feel better about yourself more broadly.
Right.
Okay, so now, but also you said 2, and you didn't say 10.
No.
So how come it isn't a little higher than 2? Why isn't it a 3 or 4 or 5?
Because I really don't have oomph. I don't have the... I've tried to make myself, and I'll get up and I'll say, okay, I'm going to do this, this, and this today. I get up, I get my breakfast or whatever, take my insulin, and then I turn around and say, okay, I'm going back to bed. I don't want to see the world today.
Instead of seeing our patients as ambivalent, we often believe they are being purposefully uncooperative or non-compliant. And the automatic way we often respond is to take one side of the person's ambivalence, to demand compliance or to threaten dire consequences. Unfortunately, this typically leads to a chilling, polarized environment in the clinic room, where the patient's inner ambivalence is not resolved and positive change still does not happen. Instead, why not recognize the patient's ambivalence out loud and make that a part of the change process?
So even though you can see that it might have some value, when you think about why it isn't more important, you say, from your own history, from today, from yesterday, that you're just not going to find the energy, the physical energy to do it. Okay, so you can see some value in it, potentially see some value in it, but on the other hand, it's hard to imagine that you'll have the energy to pull that off.
Right. I don't have the strive that I used to have,
What we're doing here is moving beyond just talking to people about their ambivalence, about whether or not they see some behavior change as important, to problem solving with them so that they can begin to see, hopefully, that making some positive behavior change truly will be worth their while. Now, in your heart of hearts, the reason you said it's 4 is that you kind of know, at least abstractly, that if I take these, it's probably going to be good for my blood sugars and good for my health. And you and I both know that's true. But it's when you see it that you're more likely to do it. So my thought is this. I would think you need to know exactly what your A1C is right now,
Okay.
so that we have that to compare to a couple months from now. And if it makes sense to you, and you think it's possible, I would think, why not be willing to just for a period of time, say 2 months, maybe 3 months, to take those medications super faithfully every day. And then 2 to 3 months from now, you get that A1C test done again. And if it's not significantly lower, then you're right. But if it is lower, it should, hopefully, would be the proof that you need, that you can step back and go, I'll be darned. This stuff is doing me some good.
Yeah.
What do you think of that?
I think that's great. I think I'm going to take my medicine.
The purpose of exploring importance is to help the patient recognize their own ambivalence. When this is done in a respectful, non-judgmental manner, the patient comes to see the discrepancy between his or her current behaviors and his or her own desire to be well. Almost automatically, this can promote a greater interest and readiness for better self-care.
The final strategy is collaborative action planning. In this phase, what we're going to do is to really help patients boil down